told me. So define leukemia. So a brief regarding the etiopathogenesis, manifestation, how do you approach both clinically as well as lab-wise, because both are hand in hand in approach of a kid with leukemia, kid or anybody with the suspected leukemia, clinical as well as lab, both are important, and understanding the basic management. So having said this, when I started preparing my slides, I understood that I have a Herculean task to cover all the aspects. So basic by definition, what is leukemia? Leukemia is basically any uncontrolled proliferation. So cancer is basically uncontrolled proliferation. Leukemia, basically it's the hematopoietic cells. So what we find is even an asymptomatic kid also can present with an incidental finding of, say, anemia or thrombocytopenia. So they can present with, and this finally the diagnosis being acute leukemia. So this proliferating WB is what they do. They fill, say, this room. This is like the marrow. Imagine this room as the bone marrow. So how many people can sit inside? Say, hardly not more than 50, comfortably. So with social distancing, we are improving upon that. So if the marrow is filled with leukemic cells, blast cells, so the other lineages like the red cells, platelets, they can't get out. They feel suffocated. So eventually the anemia, thrombocytopenia is manifestations predominantly of the marrow packing. So classification, basically with the speed with which the leukemia develops, chronic, acute, basic. So acute leukemia, chronic leukemia, this is a basic classification. So then acute and chronic, again, two arms, lymphoid, myeloid, okay, because the treatment differs, okay. So these are basically lineage committed leukemias. Once you are committed to a lineage, then that is labeled as such, myeloid versus lymphoid, and the speed will dictate whether it is acute or chronic. So management is different. We all know that. Acute leukemia, that is, they present with more complication, emergencies, and chronic, they do present with emergencies, but usually they have a slow course like CML, CLL, because most of these chronic leukemias like CLL, CML, we do find in the adult world. And you have the JMML, that kind of stuff in your pediatric thing. So how does this leukemias occur? What drives the leukemia? Basically, these are the mutations. Now, hematology is basically not just the chemotherapy. Blindly you give chemo, DNA damaging drugs. No. This is the era of targeted therapies. So they studied even the gene expression profiling, genetic and molecular background. So now the leukemias are called as per the molecular signature, not just even lymphoid leukemia. No. Then we need to know what is the molecular signature, pH positive, pH negative, pH like signature. So those are the drivers of these leukemias. So one or more mutation in the genome, basically it's in the pluripotent or multipotential progenitor cells, that drives these cells, and activation of oncogenes, proto-oncogenes, inactivation of tumor suppressor. So these will trigger a cell to get into the division mode. So they continuously divide, additional mutations occur. So always we know that two Knudsen, two-hit model of mutagenesis. So these all mutations we know, AML, ETO. This is 821 transfer. Okay. So various levels of mutations can occur at the differentiation level, proliferation level. So enhanced proliferation and differentiation block. So to degree with which the differentiation block occurs or the proliferation is triggered will define what kind of presentation. Say if it is a promyelocytic leukemia, it's more of a differentiation block. They get arrested at the promyelocyte level. They don't go forward. Okay, then there is proliferation. These kind of promyelocytes will proliferate. So that will lead to eventually the acute promyelocytic leukemia. So what is the trigger? It's the PML-RARA translocation. Then differentiation arrest, then proliferation. So the stepwise it will, and when additional things happens, which still the research is going on. Other mutations, FLT3 mutation, how they affect on the proliferation. So again, what I said, myeloid maturation. This is a normal maturation pathway. This get arrested at various levels. And this myeloid AML is divided as per morphologically. Initially or even now it is the 2016 WHO, they divide as per morphology. Myelocytic, myelomonocytic. It's a morphological classification which has taken from the FAB classification. Now they have added genetics to it. As in the 2016, it is more of genetics. So again, the same thing. There are much more mutations. Icaros, these are all transcription factor mutations. The hematopoietic cells. I don't have the cursor, so the lymphoid progenitor pro-B cell eventually getting into a lymphoblast. Other one is the a rough description of the how the treatment, it kills the proliferating cells, but one cell is left behind, that is some minimal residual. Why MRD is important? Because one cell is sufficient to cause a relapse later, or even to make it a refractory disease, or even a lineage may switch. Say ALL patient received chemo, later he might develop AML. It's a secondary leukemia later on. Okay, the same thing. So explaining different kinds of symptoms. This lymphoid stem cell, uncontrolled proliferation, decreased normal cell. I said the room example, RBC megakaryocyte. These are the important two other lineages apart from the WBC. So though WBC lineage goes up, you won't get space for the other two, resulting in anemia, thrombocytopenia, etc. Okay, and the WBCs, they are dysfunctional. They are leukemic cells. They do just harm. They are not of any use. So they are dysfunctional. There is always a chance for infection, sepsis. These are the complications which we see in leukemic presentation. Okay, then this proliferating cell infiltrate into the lymph node. This I told about the marrow. The same thing will happen in the lymph node, spleen, liver, hepatomegaly, splenomegaly, lymphadenopathy. Okay. So why we fear leukemia? Why we or anybody fear leukemia? Because of the risk of infections, bleed, nutrition issues, pain, because of the expansion of the marrow, and fever, infection, tumor, lysis. These are all the complications which I will be coming into the detail. So there are several factors. So I said mutations. How these mutations occur? So there are very much syndromes which are described here, which are predisposing a kid into leukemia. Okay. So, and environmental factors. I'm not going to details. There's a bunch of drugs and radiations, etc. So, not boring. I've taken two cases. These are two cases which we are managing baby. Okay. First one. So probably you might be knowing the first kid, which we did IT today in ICU. So, it's a 6-year-old boy. So he presented with fever, low-grade fever and a hip pain. Okay. 2 weeks duration, short duration, no much of comorbidities, other immunization, that stuff all are. You might excuse me for, because I deal more with adult hematology and thing, and so the nutrition that I don't tend to a full pediatric kind of a case history. This is we know we are talking about leukemia. This is leukemia case. I'm not speaking about any DDs. So what happens when somebody presents with fever, kids? So they usually say viral fevers, hip pain, the JRA, rheumatoid arthritis, that the juvenile rheumatoid arthritis, that kind of stuff. So many of them might tend to treat them with steroids, NSAIDs, of course, analgesics, and even steroids. So what happens when they get steroids? So there's a chance that it could be ALL, and there might be a steroid response to that, and we might mask the blast. The blasts are very sensitive, especially lymphoid. They will melt. So this is commonly what we. So then the steroid response is difficult to assess. Later they might become. The diagnosis will be missed unless you do a marrow or you get a blast in the periphery. Okay. So this kid, on examination itself, he was pale, looking pale, but and febrile, no fever at the time of examination. Other general vitals were stable. Spleen was palpable, 1 centimeter. Small lymph nodes, 1 into 1.5 centimeter nodes. Testis is normal. It's why testis? Because examination in lymphoid malignancies, or even we are talking about leukemia. There are other neoplasms, testicular seminomas, that kind of stuff. Okay, so testis examination in a approach leukemia patients, suspected leukemia is important. Males. Okay. And nervous system, because there is always a predisposition of this leukemias for CNS infiltration. So any CNS involvement. Okay. Having said that, parallelly I'm presenting the other case, 15-year-old, a much elder girl. She's very obese, 106 kilos. So she presented with petechial spots, that too of 2 weeks duration. So they were evaluated elsewhere, treated as ITP. Okay, with pulsing steroids, methyl prednisone. 2 days she received, but nobody looked at the smear. Okay, so ITP, before even thinking of steroids, you should be 100% sure that it is not something else. Okay, in India we say that okay, we start steroids even without marrow not required, but at least a smear, that is a mandate thing in these kind of scenarios. So pulse steroid, then a smear was reviewed, then I'll come into it later. Okay, so examination wise, she is obese, petechial spots were there, mild pallor, vitals were stable, organomegaly or CNS, nothing. Okay, so let's stop there. I'll segment by segment, I will brief you the case. So common symptoms, what all symptoms do we have? Like systemic symptoms like weight loss, the most common I have described here. Fatigue, ability due to basically 3 linear symptoms. Anemic symptom, this is HB axis, anemia, fatigue, that. Second thing is the white cell lineage. Infections, symptoms related to hyperleukocytosis, leukopenia, both. Basically infection, they're dysfunctional. Even though the count is normal or high, they're doing nothing. Okay? So there's chance of infections, sepsis. And third line is the platelet related symptoms. Usually thrombocytopenia, or even platelet could be normal also. So bleeding manifestations like that. Then organ related. Infiltration to any organ, testicular pain or liver, spleen, major organ infiltration. Okay, bone pains because of the expanding marrow. So we saw in the first case, bone pains. Okay, so there are certain clues which will give you like, okay, this could be an ALL. Acuteness of the presentation, okay, probably acute leukemia. Now lymphoid or myeloid. So these are not clear cut compartment. This okay, this if we have this no. But these are clues which can overlaps occurs. So lymphadenopathy, spleen, liver, probably lymphoid, but not like it won't happen in myeloid. Okay, testicular involvement, more in lymphoid. CNS infiltration, lymphoblast are more prone to this thing. But at the same time, bleeding manifestation. If I'm getting bleeding profusely out of proportion, I would think of more of a like a APML, promyelocytic leukemia. Okay. Sarcomas, extramedullary masses, tumors. So I will probably think of a myeloid sarcoma, not a lymphoid. So how will you work up? So you have a kid, there's like 2 cases you have in the OP casualty, wherever you encounter. So you have the history, you have the examination. Okay. So what generally, this is in part, most of this we'll do for any workup, like a fever case or any general approach. But I would more hematological point of view, I will describe in a hematological point of view. So complete blood count. This is the first and foremost. Nothing can replace a CBC. If you get a CBC, that itself can ensure the diagnosis. Okay, anemia, the type of anemia. Okay, and counts can be high, leukocytosis, cytopenia, or even normal. But the differential will give you. Okay, how do you interpret a normal differential? Like the lymphoid, myeloid in a kid. What happens? Any idea? Like the differential. What is the normal differential in a say 4-year-old kid? It's a lymphoid basically, right? So what happens is usually at the time of birth it is neutrophilic leukocytosis. Leukocytosis is neutrophil predominant. By the 10th day, 1 week or so, 1 week 10 days, it will switch. Lymphoid will come out. Okay. It will go on lymphoid predominance, will stay till like 5 to 7 years. Then ulta, neutrophil will come out, and that will stay, right? So interpretation of DLC is always with the age. Okay. Then coming to the platelet, usually in leukemias it goes down, thrombocytopenia, because the megakaryocytes are the most frail in the marrow. So it is the first to hit. Okay. Then peripheral smear. I told you already in the second case, it's a peripheral smear or even the CBC. CBC, okay, promyelocytes may not be, but the peripheral smear will get you the diagnosis. Okay, and complete panel. I have separately written as a tumor lysis parameters because we are talking leukemia. I might talk since being leukemia, and it's not okay. We'll go this no. So tumor lysis parameters means the creatinine. So I'm specifically looking at if there are any tumor lysis or not. It could be either spontaneous, like without any treatment steroids, or secondary to steroids. Because somebody, a first patient, fever pain, somebody have given him steroids, I can expect tumor lysis now. Okay, so that history is very important. Whether he have received steroid, look into the previous records. Don't ask them, just verify it to yourself if there are any steroids on board. Okay, so if you are getting out of proportion creatinine, uric acid, so definitely that he might have received steroids. Probably he might be an. Okay, so you don't get a tumor lysis like picture in like a JRA or okay, or in just in an ITP. So that is important. LDH will give you a rough idea because LDH is a non-specific marker. It tells you that some cell damage is happening. Okay, there are various fractions. Mainly, we look at the LDH2 fraction. Okay, that is the reticuloendothelial cells. So, and one is from the heart and the RBCs. Okay, so we can't separate it on LDH2, and what we assay is mainly LDH2 kind of fraction. So, can be elevated in hemolysis. That we look into the bilirubin, other parameters of hemolysis. So LDH can be elevated in B12 deficiency. That also the picture is different. That can also may present with anemia, thrombocytopenia, MCV will be high and no blast. So that's a different workup. Okay. So LDH will give you a rough idea. Liver function, CRP, is there any underlying infection? Coagulation profile, absolutely important, especially in case of a out of proportion bleeding, like APML. Okay. And even PTNR, it's not sufficient in acute promyelocytic leukemia. It may be normal. You have to look at the fibrinogen. Okay, because you have to correct it. Platelet, even if the PT normal patient having bleeding thrombocytopenia, if you don't correct the fibrinogen, it might be 50, 60. The patient will bleed. The mortality is maximum in the first initial presentation, say in 2 weeks, 3 weeks. If you survive, or if you can manage the patient out of the first induction and all, you will have a 85-90% survival. That is APML. So first one, it's the absolute window to save whoever is suffering with APML. So very good result in APML. Very gratifying to see. And CSF, because this not at the baseline, but once you know that it is leukemia, if it is a lymphoid, we do a CSF study. Okay. So step by step, peripheral smear, just brief acute lymphoblast and myelo. So, and other chronic leukemias, just mentioned CML, how they differ from acute. Acute leukemias, basically there are blasts. Okay, the morphology and in myeloid, there must be myelomonocytic monocytes, all from the morphology. Basically, WHO, FAB, the later WHO, they are morphological classification. This M1, M2, all those are morphological, myelomonocytic. They are not flow based. They are basically what you see in the smear. Okay, so percentage of monos, myelos will determine whether it is monocytic or myelocytic, and this is a lymphoid. And you can see there's another slide. Basic difference between a lympho and a myelo. Lymphoblast is more condensed. Okay, thin rim of cytoplasm. This is more open chromatin. Okay, nucleoli you can see, and you can see an OR rod. See that OR rod. That's more in that will give you that it's more of a myelo. Even if you look at the smear and you find an OR rod, and you will be pretty sure that it is a myeloid AML, not AML. Okay, continuing. So the boy CBC, I think that's HB, TLC, neutrophil, lymphocyte, platelet. Okay, slash. I'm given the name. So HB, there is a lymphocytic leukocytosis. NSP, 21,000 is the TLC, of which 92% is lymphocyte. And there is mild thrombocytopenia, anemia. Okay, and smear. That will get you the diagnosis. 45% blast, high NC ratio. At this point, okay, I might say that it could be lymphoid, but I'm not sure. Okay, so this point, peripheral smear, there is cytochemistry, old method, that is we stain the blast with stains like MPO, PAS. So that will get you an idea. If MPO is positive, the more likely myeloid. PAS is more for ALI. Okay, but the final diagnosis will come from the flow cytometry, typing, absolute typing. LDH, can see it is elevated 605, and LFT is fairly normal. Creatinine, uric acid, that TLS parameters. What all in TLS? I'll tell you that that's classification criteria for TLS. So that's essentially normal. PT APTT is normal. Fibrinogen is 240. Okay, but I can skip fibrinogen here because there is no much of bleeding manifestation. It's not like an APML kind of representation. Platelet is fairly reserved kind of thing, 1.2. Okay. Cytology, it is at a later date. I am including here no CSF blast or any typical cells. Okay. Whereas the other side, she has what counts as 6.5 and mainly neutrophil window. It's a neutrophil. 84% is a neutrophil, but they are promyelocyte basically. They fall in the neutrophil window. Severe thrombocytopenia. That's why she got steroids. And after getting steroids, one thing, steroids are wrong pick. And if it is an ITP, usually it will improve. So it remained as thrombocytopenia itself, and then only the smear was rechecked. That's a great. It's not the way. Okay, smear was showing promyelocytes. Faggot cells were seen. What is faggot cell? It's ore rods. We have seen that bundles of ore rods stacked like they will. That's pathognomic almost because it's a smear diagnosis. APML means it's a smear diagnosis. Even if you suspect APML, start at one. Okay, there's a wording. I think which book. Even if you suspect APML, you are justified in starting ATRA. This is what this William Osler, he will also approve. So some book I don't remember. Okay, so MPO positive. MPO basically it's a myeloid marker, thrombocytopenia. LDH is elevated, LFT, creatinine, everything is normal. You can see the PT. PT is prolonged, and fibrinogen you can see it's very low, 82. So in this case, even if I correct only platelets, she will again bleed. Okay, this needs aggressive correction. Otherwise, we will lose the patient to IC bleed because mortality is very high in the first 1-2 weeks. So fibrinogen is very essential in suspected APMLs. Okay, CSF not done. Should I do CSF? First of all, APML, I'm not, no CNS symptom. First thing. Second thing, I don't want CNS, unless she is having symptom, I don't intend to give a CNS prophylaxis or anything. Third thing, she's having a extreme coagulopathy situation. I need not poke her. Okay. Okay. Coming to the next set of investigation. What do you do next? Okay, you have 2 cases parallel. Okay. So marrow, you have to do a marrow. Why marrow? Because I can do flow from peripheral blood itself. Okay. Only when you can't do a marrow, then only peripheral blood flow. Okay, because marrow is the sample which is recommended for cytogenetics. Now we need to type. Then, if it is ALL, then further molecular or cytogenetic typing we need. Okay, to characterize this is the final diagnosis. Okay, so marrow immunophenotyping. Can do immunophenotyping typing by 2 methods. One is flow, running blood. Okay, then if you get to 45% blast in the periphery, that is sufficient. You can do the flow from peripheral. Okay, immunohistochemistry. Say if you needed urgent diagnosis, marrow, the patient came in a Saturday night. Okay, or a Friday night, and marrow is not, if a patient is sick, you can't do a marrow. So peripheral blood flow is sufficient. You can get an early diagnosis. Anyway, you will be doing a marrow later. Okay. Second method is immunohistochemistry. That is in the bone marrow biopsy. But in leukemias, we do prefer flow because there are markers which we can do only in the blood. And even the biopsy also, you do markers, say CD3, TDT, that kind of markers. Okay. Karyotyping, again marrow sample, heparinized marrow sample. We don't do karyotyping. They culture the marrow sample. So what I do is, when you do a marrow, take samples extra, 2 heparin, 2 EDTA. So that will get you the cytogenetics, and you need not. So once you do the marrow, okay, ALL, then you can again go back and do marrow. So keep the samples, heparin for cytogenetics, and EDTA for PCR, fish, whatever molecular panel you want to do. Okay, NGS, nowadays they do NGS, extensive panel workup for AML and AML ALL both. So marrow, we usually do posterior iliac crust. Okay, but in babies less than 1 year, we can do this tibia, medial and just below the tibial tubercle. Okay, I have done only one tibial tubercle, that to say remain here. Okay, okay, and sternum usually do aspirate, not biopsy, because the area, because we can't go deep. If we don't do carefully, there is a potential risk. Okay, and we do by the first one, Jamshidi is what we have here, Jamshidi native. Okay, and these are cytochemistry stains, which I said MPO for myeloid and PAS in ALL. So this is briefly to sum up ALL versus AML. Okay, ALL predominantly in children, but also in adult also. This is not clear cut, not like a compartment here, there, no. There will be overlaps also. Lymphoblast, common cytostains which are positive. So coming to the cases. Case 1. So 6-year-old boy had a aspirate, has 90% blast. Okay, it is MPO negative. So it could still be AML, could be AML M0, that undifferentiated kind of thing can be MPO negative. Biopsy, again suppressed other series. Okay, predominant cells are blast. Flow cytometry, there's a B cell markers are positive. 19, 10, 34 is their premature marker. Cytogenetics 46, normal cytogenetics, and molecular panel is AML. It's a good prognostic marker, 1221. Other markers are negative. Okay, so we finally arrived at a complete diagnosis. It's a BALL. So LL from the and B from the flow, from the markers, then normal cytogenetics, and it's a good prognosis. Okay, but with this presenting TLC and the age, he falls into a intermediate risk. The risk stratification is different groups have different. This is from the BFM group. So if you want to treat, you classify, okay, intermediate, standard, high risk. Okay, so this further on will be a treatment classification, which we decide on treatment, how intensely you have to go. So if it's a high risk, you might have to think of transplant also. Okay, so that time if it's a high risk, I will, okay, is there any siblings? I will start thinking of any sampling HLM transplant. Okay, so flow cytometry. Flow, what you do in flow? Basically, the cells are made to pass in a single file, one by one cell at a time, and you pass on light. Okay, and what happens? Light goes through the cell, and depending upon the particles, I don't know, this picture is not visible. So light, if it is a granular cell, what happens? The light will pass through. Okay, except the nucleus. If it is a granular cell, the light will scatter. Scattered light will go here again, and these are picked up by what? Sensors, and they plot. So granular cells will go up that area. A granular lymphocyte will come down. So these are the areas which will show you. This is the area which the normally a cell will fall. Okay, blast will have an area, lymphocyte will have an area, neutrophils will have an area, like that. Okay, so and based on that they plot a chart. Okay, this is a 2x2 chart. Can you see? Side scatter versus CD45, first one. Okay, that P1 red color, that's the area where the blast will come. Okay, so you select only that P1, so that only the P1 will be shown in the next subsequent graphs. Okay, coming to second, 19,103. Okay, so 19, usually the 4 quadrants, this will be positive for 19. This 19 is the what do you call it, x-axis, right? X or this is y, this is x, right? Okay, so 19 positive will come in the this one here. Okay, 103 positive here, both positive here, both negative here. So this is 19, 103 negative, and here like 25 and 11, both are negative. This is CD19, this TDP, both are positive. So CD, cyto, CD1 and TDT. So this is how they interpret flow cytometry. So if the earlier we saw 1920, so 1920, so both will be positive. It will be in the both positive. So that way. So anybody can give a try. Say these are the blast. What about CD10? 19 and 10 both are positive. That quadrant both are positive. Okay. 28 both are negative. The other one 34 HLA-DR. So 34 probably negative, HLA-DR positive. And here 13 and 3 negative. Okay. There are some heterogeneous because some cells might have some aberrancy, so that might fall into. And this CD33 is negative, HLA-DR is positive. TDT is positive, that's a marker of immaturity. And CD79 is positive. MPO, that is a myeloid marker. And TDT, that's an immature marker. So what all are positive? 10, 19. Okay. Then HLA-DR, immature. TDT, immature. CD79, TDT. Okay. HLA-DR again. So myeloid markers are negative. This MPO is negative. 13 and 33 is negative. And so 19, 10, HLA-DR, TDT, 79. All are B markers. So it's a BL. Okay. This is how flow is interpreted. So whenever you get a try to, like, this is fun. Here the like, okay, it's a BALL with some aberrancy in 30. Okay, some aberrancy. Okay, coming to ALL. Imagine this as our kid. Okay, so various stages of BALL blast, pro, common, pre-B. Previously the CD10, Kalla positive ALL, but now it lost the significance in the wake of newer cytogenetics molecular markers. So nobody say like, okay, Kalla, this kid was a Kalla positive BALL, but doesn't make any prognostic significance. So these are the common markers which are positive BALL. Okay, some myeloid antigens may be co-expressed. That will give you a poor prognosis. Certain markers will give poor, aberrant 13, etc. Okay. And how do you classify? This is a little bit of the I will rush through. I don't intend to bore you. Okay. If you open the WHO, this is a Bible. These are the classification. NOS is where these are the molecular markers which will define. It's not just BALL. It will be with 922, with MLL, with 1221. So what is our kit? Which one? Okay, 1221. So this is our final diagnosis of the kit. And if all these are negative, then it is NOS. Okay. And this is the provisional entities. One is B lymphoblastic lymphoma. So they behave more of a lymphoma kind of thing, but with say less than 25% blast in the marrow. Okay. And sites, mainly ALL is basically in the marrow, blood, and lymphomas basically mediastinal mass, that kind of stuff, and less of a blast. So they are lymphoma. There's some entity in the 2016. The morphology. Okay. Can anyone give a try? Okay. 22, 34, 19, TDT also. 22 again. Okay. So basically BALL. This is the corresponding immunohistone 79 APAX, which we cut in the biopsy, which stain for these stains. But in flow, you can match. You can change the 34 to 40. Anything, mix and match you can do. Okay. So the CD10 now lost. Previously LL they used to call it L1, L2, L3. Their morphological classification, how they look, small, okay, small to intermediate size like that. But they lost significance. Now that molecular and flow will decide. So I need not go to the FAB classification now. These are the common morphologies which we see: hand mirror appearance, cytoplasmic vacuoles, Burkitt lymphoma, starry sky pattern, and all. Okay. So differences between the LL1, 2, 3. Small lymphocytes, small, large lymphoblast. So L3 is more aggressive, kind of a Burkitt like of presentation. Okay. So recurrent genetic abnormality, this is about NOS, which we talked about. This is a recurrent genetic abnormality, which I showed you already. Where is 922? What is 922? Philadelphia. So Philadelphia, this 922 translocation, there are three types: P190, P210, P230. So the P190, three types are there. Okay, P210 is more in CML. Okay, this P190, 922 translocation. So this respond to, we have to add on TKs, think of transplant. These are high risk leukemias. Okay, second high risk is a MLL, mixed lineage leukemia. MLL rearrange. This is anything paired with 11, 4, 11, and there are many AF4, MLL, all are high risk. This 12, 20, these are ours. Usually good prognosis. Okay, and frequent expression of 13, which we can see more than 90% cure rate. Okay, hyperdiploidy, more number of chromosomes. Okay, hypodiploidy is less than 46 number. So all variants. Something called BCR-ABL like. Okay, these are newer things. They have the behavior of BCR-ABL but don't have 922. Okay, those have the gene expression profile. Gene expression, when they did the gene expression profiling, they have their heat signatures are the same like a pH, but they didn't have the pH, and they behaved exactly like pH. Bad prognosis. Okay, and some of them have mutation which can be targetable with TKIs. Okay, so this category is the newest one. Okay, so especially in children, these are the various pathways. Basically, there is a kinase domain pathway which is active due to mutations in any of these, ABL, JAK2, but it's not BCR-ABL, behaving just like BCR-ABL. That's called BCR-ABL like. Okay. Okay, CRLF2, CRLF2 if it's positive, which we don't usually see here, but if CRLF2 positive, we have to transplant. Okay. Icaros is one of the mutations which is gaining very much discussion these days. I did my thesis in Icaros deletions. Okay, so this is basically my study. 100 patients we analyzed Icaros deletions in ALL. Okay, basically BALL. We got say 43%. This Icaros more commonly occurs with the pH positive. Okay, so riskier that kind of a gradient. Okay. And BCR-ABL negative is 12%. These are various variants, haplotypes which we got. Okay, flow plots. So Icaros mutated will have a lesser response to chemotherapy as assessed by the day 33 marrow. Okay. So these are the conclusion. 18% incidence in BLL. We did the study in 100 patients, 100 or 99 patients. Okay. So, and coming down on these are IAM 21. These are also new classified. Will be usually in children. Okay, their characters. You need not know all this. And now we talked about B. Now it's a T. Again, lymphoblastic leukemia versus lymphoma. So T lymphoblastic lymphoma, usually kid will present with a large mediastinal mass. If they have blast in the peripheral blood or in the marrow more than 25%, you call it a TALL. Okay, or without any mass, they can present just like the BALL. It's a T morphology, CD3, CD4, CD like that. Okay, so these are the differences between TALL versus LBL. Okay, this is a basic concept. Is this is a person more like with a mass. Okay, these are the markers which we positive for the CD1, CD. That's all the T cell markers. Okay. Okay. Anybody try? 4, 8 positive, MPO negative, 3 positive. So 4, 8, 3. All are T cell markers. Coming to CD2 positive, 1A positive, 7, 3, 5, 2. All are T cell basically. CD22 negative. And 13 is negative. That's a myeloid. 33. 13, 33. Both are negative. So myeloid negative, B cell that is CD22 negative. Yes, you can see 1920. So 1920, that range is B cell. Younger, 1, 2, 3, 4, 5, not one time. Just the younger is the T cell, and still higher, 1333. Those are the myeloid. MPO is a myelo. So you can do these are all negative quadrants, right? Last row. 10, 19, 20, 36, 33, 10, 19, HLA-DR 117, those are all negative. So this is how you interpret a flow. Okay. ETP, that's a subset of ETALL. Okay. So this has a bad prognosis. This is basically CD1A negative and CD5B of the T. Okay. So this is a separate category and you need to go aggressive. So overall prognostic factors in childhood, and these two, there are different description by different group. German group, there are different groups. Okay. So continue. Case 1. Median risk. As per his age, his age is 6 years. First TLC is 21,000. So basically, and BALL, no 922. Good steroid response. Day 8, blast was less than 1,000. Marrow 1 month later, day 33, marrow was done. Minimal residual disease was negative. Okay. No higher cytogenetics, normal cytogenetics. So started on BFM protocol. That's a German protocol. Berlin, Frankfurt, Munster. Multi-center, 3 cities of Germany. Okay. Presented. Now he's going well. Now, as we speak, he's in receiving third high dose methotrexate. That's the consolidation part. Yeah. 50 Oh, yeah. He's being shifted to what? Yeah, good. Shift. If it is okay, shift. Okay, so we have live updates on the patient. Okay, so he's doing good. Okay. So basic treatment arms are BFM or BFM-like. There are COG, St. Jude, several groups are there, but we normally we adopt a BFM protocol. So basic management is divided into 5 steps. First is a pre-phase. You just give steroids to debulk. Okay, TALLs, even with a single shot of steroids, it will come down crash 0. Okay, that's why we prefer not to give steroids. Usually peripheral practices give steroids. It's a panacea, everything steroids. Okay, but even with one steroids, you have to be very careful about the history. It will go down. Okay, then you miss the diagnosis. So pre-phase for 7 days of steroids and 1 intrathecal. This is to debulk. Okay. Next is induction, divided into phase A, phase B. 5 or 4 drug induction, different drugs including steroids. These are the BFM drugs. Includes cyclovincristin, dono, do a marrow after phase 1. Phase 1 means day 33 marrow. If MRD is negative, you're good, like this kid. Okay. Phase B, again, different subset of drugs, so that the leukemia cells are targeted by different hits. Like you hit by one weapon, next weapon, like that. That's why the different phases have different groups of drugs. Okay. Coming to consolidation, this is basically to target the CNS. High dose methotrexate, IT methotrexate. They penetrate blood by some protocols use cytarabine, steroids. So these are the drugs penetrating blood-brain barrier, and so that this CNS and testis, these are the reservoirs. Okay, so even if one cell seeds there, it will come back, relapse. Okay, so we have to be very clear on our why we are giving these drugs. Okay, even in exams they might ask consolidation. So our kid is in consolidation protocol N, that is methotrexate. We are giving very high dose method, 5 gram per meter square. This is the third dose. Okay. Next is reinduction. Again, that also phase A, phase B. These are the drugs which use in phase and phase 2. Yeah. Okay. So then maintenance to prevent relapse. Usually it goes for the 2.5 years maintenance, so that the leukemic cells won't come back. And if they stay in remission for say 4-5 years from the start, they are declared cured. And the cure rate in BALL, especially this age, is above 90%, 90-95%. Okay, in good centers. So this is maintenance what we do. 6MP method. Some protocols use pulse steroids and vincristine also. Okay. So there are certain emergencies. This is the routine leukemia chemo management, but it's not. More important is you have to salvage the kid from certain emergencies. Okay. It's not about giving drug. It's about anticipating the complications. Anticipation is the key in hematology. Okay. SVC syndrome, especially T lymphoblastic lymphomas. Tumor lysis. Okay. Tumor lysis syndrome, this is a criteria. This is a Cairo and Bishop classification. Okay. More than 2 lab and clinical, at least 1. Okay. At least 1, or it's not about the defining the criteria. you anticipate, even if uric acid is going up and you know that you are given steroids, you have to treat as prophylaxis for 2 years. It's not like, okay, I'll wait for the criteria, then you will lose again. Okay. Now, most important, febrile neutropenia. Every chemo, there's a tendency for the counts to go down, and febrile neutropenia is an urgency. Okay. So more than 38.3, TLC less than 500. So the or even counts, you know that counts will fall. Today it says 1000. You need not wait for 500. Okay. So growth factors, and this is what we follow. Piperacillin, and if neutropenia, you start on dual to cover ESBLs also, piptas, amikacin, and then 48 hours if not fever, switch upgrade to meropenem. 48 or even 3 days. If you suspect fungal, especially Myelo, you add antifungals, and other eventually you consider basic depending on the symptoms like PCP, other pneumonias, okay, viral, etc. Okay, new chemotherapies. These are the newer drugs. Okay, liposomal, clofirabine, nelarabine, etc. Targeted therapies. So basically now it is the era of targeted therapies. If you have a pH positive, you can use TKS. Dasatinib crosses blood-brain, so it is better used rather than imatinib. Now there are promising studies. CD20, rituximab, CD22, inotisumab, BiTE, this is a bispecific, blinatumomab. Okay, then MRD. We are not going to details. It's a topic in itself.
4950 വളരെ മിനിമം പകുതിയുള്ളൂ.
Okay, so daratumumab. This is from our group only. We gave daratumumab for an ETPL, refractory relapse. Out of no choice, we gave the daratumumab, but they responded very well. One is a pre-transfer. We took him up for a transplant also later, and one patient post-transplant MRD positive. We gave daratumumab. Excellent response. Okay. So this article particularly is one of the most read articles in the last 2 years. This is our group from Rajiv Gandhi. Okay. This girl, now newer, we are moving newer things. She's Emily Whithead. Okay. She's the first patient of CAR cell therapy. Okay. She's 5 years out of her treatment, and she's absolutely cured from the. She was a relapsed refractory BALL. She underwent CAR therapy in Pennsylvania, Philadelphia, under Carl June. He's one of the pioneers of CAR cell therapy. So this all I am saying because you have to just briefly, these things are happening only to prime you. Okay, CAR cell is basically taking out the patient's T cells, engineer it, insert the vector, and they will give you, say, you have to target CD19. So these are T cells. Insert CD19 construct, multiply, culture, and sufficient quantity, you put it back. And they specifically go and target the CD19 positive leukemic cells. So the Emily, that patient is the first patient. She's cured of this. And that's a kind of that CAR T cells will go around for continuously. And it's a kind of a continuous killer. Okay. And that's a machine, this is in-house. When I went to US, Cleveland, they were making in-house CAR T cells. Normal cost will be 3 to 5 crores. Okay. They were making manufacturing for 25,000. Now the Bombay group, they're in collaboration with IIT, TMH Mumbai is trying to develop in-house. They started the trials. It's a Clinimax prodigy. This machine will cost you 2.53 lakhs. You need a GMP lab. GMP means you can't do it anywhere. Like, okay, we bought the machine. Okay. So I don't know, this group is, I don't know, we finished lymphoid. So Myelo will rush if you want. Okay. So Myelo is basically an malignancy of the elderly. Pediatric AML, basically, I've given the age-wise distribution. Majority are ALL. Less than around 14% is 14, 13, 24, 36. These are the incidents. Okay. Flow chart. This is basically an adult algorithm. If there's any treatment received prior, it's a therapy-related AML. There's any recurrent abnormality like 821 in version 16, like 1570, that's a promyelocyte, then treat accordingly. If not, previous MDS, treat accordingly, and AML with myelodysplasia related changes. And whatever is less, left is a basket group. It's a AML and noise, where you get AML, M1, M2, M6, that morphological classification. Okay, like this. Recurrent genetic abnormality, you have a specific, including promyelocytic leukemia is included in that. Now nobody calls it as AML M3. It is in up, no numbering. Okay, this you need not just to see. Okay. Okay, so in childhood versus adult, okay, 821, which is our case, it's more common, 8 to 16%, 11Q MLL. Okay, clinical present, as I said, there are more of a tissue infiltration, gum hypertrophy, skin infiltration, etc. Infantile leukemia is basically less than 12 months. Okay, ALL 6 to 14, ALL 2 to 5, 2.5 to 5. These are the various infant leukemias. MDS, pediatric MDS, MPS, transient myeloid, especially in Down syndrome. Okay, clinical presentation like this: eye drops, effusion, ascites, etc. CNS involvement, lymphadenopathy. So predominantly myeloid, M4, M5, megakaryocytic, okay, lymphoid, mixed lineage. Down syndrome, ALL, all malignancies will be manifested multiple folds. Okay. Other hematological abnormalities, transient TAM, okay, leukemias. Features of TAM. I think I will rush with limitation of time. Okay, majority of the TAM will spontaneously resolve within 3 months. Few may progress to leukemias. They are extremely sensitive to cytarabine, so low dose cytarabine is the treatment. Okay. Promyelocytic. So other medical emergency, DICs, hyperleukocytosis. How do you treat AML? Basically, there is an induction, consolidation, maintenance, plus or minus. Basically, there is always a prospect of transplant. This is a tough malignancies when compared to lymphoid. Okay, this is algorithm management. So AML, how do you assess the response? Based on the blast count recovery, etc. Okay. So AML M3, I'll rush to our case 2. It's an intermediate risk APML. So started on arsenic trioxide as well as an ATRA and mitosandron, it's an anthracycline group. She developed a severe pseudotumor because of his obesity and all. Obesity in sense, she had a headache, persistent headache, diplopia, lateral rectus palsy, fundus papilledema. So we had to stop ATRA because ATRA is the main stem. So to counter that, we gave one more mitosandron in consolidation, one extra consolidation, and followed by single agent arsenox maintenance. So now she's on the last 6th cycle of arsenox, which will be taken this month. After that, this will be unfollowed, and she's doing good. Okay. So last slide about biophenotyping, which will express markers of both. Okay. There are certain criteria for diagnosing mixed phenotype. And most important, other than the chemo, is a supportive care. As I said, febrile neutropenia management, cytopenia, tumor lysis, antibiotics, infection control, and how do you tackle bleeding? Usually we get a cutoff of 20,000. Okay, if 20,000, if there is fever, we keep 20. If no fever, 10,000 is sufficient. If in case of no bleeding, we'll treat as per the need. And last but not the least is reducing the child's anxiety, because it's a long treatment and they have to be poked multiple times, multiple complications. So anxiety is a main, we have to deal with it along with we deal the medical urgencies. Okay, late complications, tumors, secondary tumors, growth problems, thyroid abnormal, endocrine defects, neuropsychiatry, especially with radiation. So majority of the groups are getting away from radiation. No radiation as prophylaxis unless it is a high risk for CNS involvement in that presentation. Okay, so I stop here.